Ladies and gentlemen, good morning. Good morning. Our subject today, as I have in front of me, is the burden of obesity. Yes, obesity, a health burden, is our subject. And I was wondering what exactly this meant, and so I got onto my system and used the word burden, obesity. And it came up with a few startling features or a few bits of startling information, which I will read out to you. It says that 2.5 billion people out of our 7 billion people, 2.5 billion people are overweight, and this represents 43 to 45% of the human population globally. 2.8 million, almost 3 million individuals will die of obesity globally annually. The scourge of obesity is with the developed countries, not so much the underdeveloped or the developing economies, but more so the developed economies. In spite of that, more than 30% of individuals in underdeveloped and developed countries are also overweight and obese. The cost per individual in obesity represents 30% of their earnings every month for obesity-related support. 4 out of 10 people, again, as I mentioned, 4 out of 10 people are obese, and regretfully, due to biologic reasons, the female population is has a higher propensity to obesity. Now, these are mind-boggling bits of information about which I know precious little. So, we have representing this topic the one of our senior most doctors in RAC Hospital, the senior most member of our medical team, Dr. Humam Sami Ali. Dr. Humam did his medical training in the University of Baghdad in Iraq and obtained his master's in a completely different part of the world, and that is Indonesia. He then went on to become a certified internal medicine specialist from a third country, and that is the Jordanian Board of Medicine in Amman. He also, of course, has done several other fellowships, including diabetes management. A vast clinical experience, like I mentioned, of more than 30 years, one of the senior most members of the RAC Hospital medical team. And for me, most importantly, Dr. Humam is my doctor. Now, I go to Dr. Humam frequently with my annual medical check, and I depend on his vast wisdom to advise me on how I should stay well. And I am deeply grateful, sir. I have mentioned it directly to you, and I will take the liberty of mentioning it on our program. Dr. Humam, senior medical professional, RAC Hospital, and my personal doctor, who I go to whenever I have needs, will be talking to us on the subject of obesity, a health burden. Over to you, sir.
Thank you very much, Dr. Kennedy, for this nice introduction. And you make it also easy for me to start the introduction. I will share my slide. I will try to make it short and also informative talk. So we will speak about the burden of obesity. Obesity actually have a big impact on the health of the individual. From my side, there is nothing to declare. As Dr. Kenny mentioned, in 2020, about 1 billion population aged 5 years and older were living with obesity. This is actually a very huge number and expected to increase over the coming years by 2035, estimated to raise to 1.9 billion of the population. Obesity is a health burden. The significant increase in the occurrence of heart and lung diseases, diabetes, lifestyle-related cancers, and other non-communicable disease is largely driven by the growing prevalence of obesity. This makes addressing obesity a priority. The obesity is underdiagnosed, unfortunately, and it is undertreated. Millions of individuals living with obesity are facing a silent struggle. Underdiagnosis and undertreatment are widespread. A staggering 64% not receiving a diagnosis. So many people around us having obesity and they don't know that their body weight is high for their age and for their height. And if we check them, we will discover that they have obesity. Unfortunately, sometimes these people they don't confess that having high weight and they are obese and they are living with their weight for a long time until complication occurs. There remains an underlying social belief that obesity is a result of lack of willpower and can lead to people with obesity being subjected to blame, stigma, and discrimination in the family, at work, or in the society at large. Obesity associated comorbidities are huge. Obesity can pave the way to a multitude of health problems with over 200 associated comorbidities. But there is a hope. Weight loss can have a profound impact on these related conditions, improving overall health and well being. By intervening early, premature morbidity and mortality can be preventable. Actually, weight management can prevent a lot of these complications. Effective obesity care require understanding the patient's individual experiences, perspectives, and goals, not just their BMI, which is the body mass index, which is a measure of obesity. We will talk about body mass index and how it is still poor to diagnose obesity and to differentiate people who are living with diabetes, sorry, with obesity or not. Conversation with the patients about obesity are not always straightforward, but physicians are vital in empowering patients to achieve sustainable weight loss and improve health outcomes through evidence-based strategies and compassionate support. Even moderate weight loss can improve or prevent complications. Weight loss and maintenance of weight loss can be challenging as physiology may inhibit or prevent weight loss. So, what is obesity? Obesity now considered as a disease. It is defined as a chronic, progressive, relapsing, multifactorial neurobehavioral disease, wherein an increase in body fat promote adipose tissue dysfunction and abnormal fat mass physical forces resulting in adverse metabolic, biochemical, and psychosocial health consequences. So, considered as a disease. And unfortunately, it is progressive. And we say relapsing because individuals tend to gain weight after a lot of struggle to lose weight. It is multifactorial, mean there is a lot of um, uh, confounder that can lead to weight gain, and of course neurobehavioral. So obesity now we have to consider it as a disease. We will come on more detail why it is a disease. So element of any disease, um, we have any for any disease we have etiology. Etiology is the cause of the disease, and we have the pathophysiology, which is the specific disease mechanism by which the disease occurred, and this will compromise organ function, leading to illnesses. Illness is a clinical manifestation of the disease. For obesity, now the traditional framing of the obesity, we have the etiology, which is the genetic, environmental, sometimes unknown, which leading to the pathophysiology, the mechanical, the endocrine, metabolic, or inflammatory process that can lead to the pathophysiology of the disease. Additional etiologies could be for sometimes medication, sometimes illnesses, sometimes mobility for any reason can impact also and leading to weight gain and obesity. So these are obesity related diseases, for example, diabetes or cancer. Now, the direct effect of excess adiposity will lead to the compromised organ function in the individual with obesity. So they will give us the manifestation of a disease. So it is obesity as an illness. So obesity nowadays we consider it by itself as a disease. It is a multifactorial disease. Genetics and epigenetics play a major role. Environmental, social, cultural, immune process, endocrine, medical, and neurobehavioral. All factors can lead to increase in body weight and adiposity. So for classification of obesity, we tend to use the body mass index to measure the adiposity and increase body fat. It is a simple way by which we can check the body mass, and it is by checking the patient's weight in kilogram and will divide it by the square height in meter. So as a classification, it is either normal weight when the body mass index between 18.5 to 24.9. Overweight, anything above 25 up to 30. Class 1 obesity is 30 to 35. Above 35 up to 40, it is class 2 obesity. More than 40, it is class 3. This is the simplest way, but unfortunately, this cannot be always applied for the every individual. Increased body mass index cannot differentiate adult with no excess fat. For example, athletes tend to have increased body weight when we check their body mass index. It is high, sometimes more than 30, but it is muscle mass rather than fat. So in such a way, the body mass index is high, but the patient is not obese. He is having high body mass index related to the muscle mass. While on the other hand, we have the people who have high body mass index and they have excess fat. This can be checked by other way other than the body mass index alone. But the patient here are classified either having no ongoing illnesses. The patient is healthy. He is active. He can do exercise. He has no disease at all, but his body mass index is high. He is considered as obese, but there is no ongoing illness. The other class is the whenever there is the manifestation of the illness, the patient is having ongoing illnesses and he's obese. So this is the class which have the complication and the impact of the obesity on their weight. What we say, the burden of the obesity on the health. So we need to use another a measurement for the obesity in order to check whether the patient is actually having adiposity and obesity. The most effective one is the waist circumference. There is another way by which we can check the amount of the fat in the body, but this is more complicated way. The easiest anthropometric measurement is the weight circumference. It's very easy. We can use the tape measure to check and the circumference of the abdomen at the level of the waist, and by which we can say that the patient have more abdominal fat, which is the most important, have a great impact on disease development. So any individual having for men, for example, more than 40 inches, that's in centimeter 102 centimeter. For men, this is considered as obesity. For women, it is more than 35 inches, that's to say 88 centimeters. This weight circumference together with the body mass index can actually classify the patient as an uh, obese with ongoing illness if there is any other comorbidities, or the patient having muscular mass and he's active, doing exercises regularly, athletic. This actually is not obese. Therefore, waist circumference, in addition to body mass index, should be implemented to diagnose obesity. We have what we say the preclinical obesity and the clinical obesity. The preclinical obesity, once the patient have increased body mass index and have high weight circumference, the patient is still having no clinical illnesses. This is an excess of adiposity, but in a preclinical uh, class. The mechanism and the pathophysiology for this, there is alteration of the cell and tissue and alteration of the organ structure, but still there is no illnesses. Clinical manifestation is minor or absent, substantially preserved organ function. So the patient is still in preclinical obesity. The detection and diagnosis usually by body mass index, by waist circumference, and also by certain clinical and also laboratory evaluation. The anthropometric here is very important beside body mass index, medical history, reviewing organ system, and further diagnostic assessment as needed. In order to diagnose whether the patient is in clinical obesity, have any comorbidities or illnesses developed due to obesity. Clinical obesity, the same for everything, but here in the clinical manifestation, the patient start to have signs and symptoms with limitation of daily activity and start to develop complications. So this is patient with clinical obesity. Here we tend to have more elaborated clinical and laboratory investigations. These included very thorough clinical diagnosis, checking the heart, checking the body organ function. Some of the patients develop severe complication and require actually critical care. At that time, the patient is having a very bad impact on the body and the health of the person, related to a lot of complications. The most important, the heart disease. So here, on this way, we can diagnose patient whether they have obesity, and on the clinical basis and laboratory test, we can differentiate whether the patient is still in preclinical obesity or actually having clinical obesity. So the definition of preclinical obesity is the state that the patient is still having no impact of the illnesses in their body. It is a state of excessive adiposity with the preserved function of other tissue and organ, and varying but generally increased risk of developing clinical obesity and several other other non-communicable diseases. The definition this remind us that the excessive adiposity doesn't necessarily result in illness, but can coexist with health. So in this way, The patient is still in the preclinical state. The patient is still having no illness, but we have to be very careful to prevent complications. That's why we need to diagnose this condition in order to start the weight management program. The clinical obesity defined as a chronic systemic illness characterized by alteration in the function of the organ or combination thereof due to excessive obesity, which can lead to end organ damage and potentially life-threatening complications. This proposed definition can occur without the presence of any other independent medical conditions, and metabolic dysfunction is not required to make the diagnosis. The Commission provides a table of specific criteria listed by organ system to confirm clinical obesity. We will come to these criteria that can define and diagnose clinical obesity. It is likely, however, that some criteria will result in debate and controversy because sometimes these criteria is a disease by itself, but we are considering it as a criteria for obesity because it results from the adiposity and increased body weight. What is remission? There is, after we can initiate very good program to lose weight. Actually, after losing weight, some of these individuals can have a remission of their disease activity, and this can result sometimes in either control of disease or sometimes in we can say reduced impact of these illnesses on the health. So obesity clinical manifestation is the adverse consequences of increased body fat, not simply comorbidity, but it is an associated risk factor with obesity. The diagnostic criteria, we come to them one by one, and there's actually more than this, but we will try to concentrate on the most important thing. So any individual have these criteria considered to have what we name it clinical obesity. They are obese and they start to have these signs and symptoms. At this stage, any one of these, we will classify the patient have clinical obesity. So in central nervous system, any signs of raised intracranial pressure, such as vision loss, recurrent headache, upper airways, if the patient have apnea related to obesity, hypopnea during sleep due to increased upper airway resistance, the signs of reduced lung compliance or diaphragmatic compliance, such as hypoventilation, breathlessness, wheezing. In the cardiovascular system, if there is reduced left ventricular systolic function, heart failure with reduced ejection fraction, chronic fatigue, lower limb edema due to impaired diastolic dysfunction, heart failure with the preserved ejection fraction, chronic recurrent atrial fibrillation, pulmonary artery hypertension, recurrent deep vein thrombosis, pulmonary thromboembolic disease, raised arterial blood pressure, all considered as a criteria of a clinical obesity. In the metabolism, cluster of hyperglycemia, diabetes or pre-diabetes, high triglycerides level, and a low HDL cholesterol level. From this, we can see there is many criteria which is commonly we see in our clinical practice for patients coming with high body mass index and increased weight circumference and having such criteria, at least with the very simply the hypertension, hyperlipidemia, and diabetes. The liver, NAFLD, and hepatic fibrosis. What we name it like it started with fatty liver disease and then progressed to hepatic fibrosis, which is very common. Renal, microalbuminuria with reduced ejection fraction, urinary recurrent chronic urinary incontinence, reproductive and the female and ovulation, oligomenorrhea, polycystic ovary syndrome, In male, there is male hypogonadism, musculoskeletal, chronic severe knee or hip pain associated with joint stiffness, reduced range of joint motion, lymphatic, lower limb lymphedema causing chronic pain and or reduced range of motion, limitation of day-to-day activity, which is very common with any obese individual, significant age-adjusted limitation of mobility and or other basic activity of daily living, such as bathing, dressing, toileting, continence, eating. Any one of these criteria, actually, our patient have many of these criteria, can diagnose the patient as having clinical obesity. Actually, this is very recent. This was published recently in the Lancet, very recently in the beginning of this year, which changed our conception of the diabetes and how we classify diabetes as preclinical and clinical. I'm sorry, obesity, not diabetes, preclinical obesity and clinical obesity. Obesity increases the risk of cancers. Following malignancy are known to be associated with obesity. This we are speaking about the burden of obesity on the health. Actually, obesity is very known to be a risk factor for developing many malignancies like bladder cancer, brain cancer, breast cancer, cervical cancer, colon cancer, endometrial, uterine, esophageal, gallbladder, head and neck, and so on. These are actually criteria well it is well known that obesity can result in such cancer. Especially, for example, we can see here liver cancer. Obesity is a reason to have fatty liver disease, which can progress to liver fibrosis and can later, after many years, can be a reason for having hepatic cell carcinoma. Other cancers like multiple myeloma, non-Hodgkin lymphoma, ovarian cancer, pancreatic cancer, very common, prostate, and also the prognosis of such cancer in obese individual will be very bad. Obesity also increases the risk of some psychiatric disorders. We now know that obesity is an umbrella for developing many psychiatric disorders like anxiety, attention deficit hyperactivity disorder, personality disorder, eating disorder, alcohol use, and depression. So, obesity by itself is linked to these psychiatric disorder. Sometimes, actually, these what we mentioned also can impact can increase the obesity by itself. Like for example, alcohol by itself can have also impact and development of obesity. Depression, depressed individuals tend to, some of them tend to eat more, and by itself, depression can cause or lead to obesity. Most important here, increasing obesity reduce life expectancy. This is something very important. Life expectancy decreases as body mass index increases. There is a study on this. They found that normal individual with body mass index between 18 up to 24.9, 80% of this normal individual can reach the age of 70. We say 80% because there's other diseases, comorbidities, a lot of other, but we expect that 80% of normal body mass index individual will reach up to 80, up to 70-year-old. If the body mass index increase to the obesity, that's to say the class 2 obesity from 35 to 40 kg per cubic square meter, the actually the life expectancy will be reduced from here the normal individual 70 reduced to 60% chance of living up to 70. If it is between 40 to 50 kg per square meter, 50% of those individuals will reach 270. This is a big impact on the life expectancy. Body mass index found to be inversely associated with overall mortality. Obesity has also been associated with accelerated aging. Patient with obesity, clinical obesity, actually they will be they will progress to aging more rapidly. The benefit of weight loss, it is not only body shape. The most important benefit of weight loss is the improvement in the obesity-associated comorbidities and the prevention of obesity-associated complications. Weight loss improve comorbidities. We will show you like what is the requested or the amount of body mass or the weight loss required to improve, for example, type 2 diabetes. If we lose 2.5% up to 15 or more than 15% of body weight, greater weight loss is associated with the greater glycemic improvement. This is true for all body mass index classes. We have studies that show clearly that patients, if they can lose 15% of their body weight, they can actually go out of their diabetes. So weight loss is very important. Knee pain and function in person with osteoarthritis, which is required weight loss. Usually we ask the patients with knee pain to lose weight. The required is 5 to 10%. They can improve the knee functionality, speed, walk distance, and pain. 10% and more required to improve the inflammatory marker that is found to be a reason for the osteoarthritis, like interleukin 6, C-reactive protein. The knee imaging study like MRI and X-ray findings usually do not change, but the impact on the inflammation will improve, and also the patients will have more knee free pain, and also they can mobilize better. For the liver disease, like the what we name it, non-alcoholic steatotic hepatitis, what we name it fatty liver disease, usually we advise the individual to lose 10% or more of their body weight in order to have a significant improvement in the liver function. And this is actually very clear in the management when we manage patients with having fatty liver disease. Usually it's very clear that it is reversible. The patient will have improved liver function after losing weight. The level of the steatohepatitis will be improved significantly, and this can prevent fibrosis. Actually, even fibrosis can regress, but some of the fibrosis can stay. So that's why it is very important and to improve the body weight and management of fatty liver disease. Depression. Usually, we ask the individual to lose weight. Can improve actually the depression and psychiatric problem. Individual with depression lose as much as weight as non-depressed individuals. Other condition, the comorbid like obstructive sleep apnea, actually can improve. Usually, this is more evident in patients who have bariatric surgery and have significant reduction in their weight. The apnea and hypopnea index can improve significantly. Gastroesophageal reflux disease, also whenever the patient have obesity and they have gastric reflux and reflux of their gastric juices during sleep, the symptoms can improve significantly when they lose weight. Renal function even can improve. The studies shows that weight loss can impact the and improve the kidney function. So obesity management is important, something that should be addressed very early in any patients coming with obesity. Obesity should be should be considered as a disease and should be treated very early whenever we see individual having increased body weight, even if they don't have the comorbidity started. So it is perceived as a chronic, relapsing, progressive disease process that may require lifelong treatment. The cornerstone of the treatment of obesity is lifestyle modification, starting with diet and exercise. For many patients, diet or and exercise may not be enough. We have many patients coming. They did their best and most of the effort to lose weight with diet and exercise, but actually they reach to the level they cannot lose anymore. At this time, we have to start pharmacologic therapies. And several pharmacologic therapies exist now that can help to supplement lifestyle changes. Individualized weight loss program should be planned and continue to maintain weight loss. So weight loss program for any adult with overweight and obesity, overall management goal should improve the patient health, improve quality of life, and improve body weight and composition. There is a challenge in maintaining weight loss. These challenges actually are actual and are physiologic for any individual. This includes interaction between the biology, behavior, and obesogenic environment. Weight weight regain is actually very common. Caloric restriction triggers biological adaptation designed to prevent starvation. This is in every individual. There is such adaptation that counteract the weight loss. In long-term obesity, further adaptation may preserve or even increase highest sustained lifetime body weight. This pre-adipocyte proliferation increases fat storage capacity, habituation to neural dopamine reward signaling, and previously obese individual may have a difficulty to if the weight gain is since childhood. Actually, they have very difficult to lose weight. Structure and interaction between patients and members of the multidisciplinary weight loss team greatly increase the likelihood of long-term positive outcome. So multidisciplinary team is required in order to reach very good weight loss and having very successful weight loss program. These multidisciplinary team compo composed of or should be like started with the primary care physician, the internist, endocrinologist, bariatric surgeon if required, nutritionist, dietitian is very important, psychologist, and exercise physiologist. Successful weight program management need to be to involve and educate the patient, assign clear rules to the healthcare team, and integrate pharmaceutical agent to complement and sustain the effect of weight and behavioral changes. So for weight loss program, patients suffering from obesity, communication is very important. Motivational interviewing with the patient. Then we will start medical evaluation by history taking, clinical examination, laboratory investigation if required, and using of the clinical tool to diagnose. And then we start the treatment. Treatment, not necessarily only medication, but lifestyle modification and diet. And then we can start orthotherapeutic education for the patient. Lifestyle like eating behavioral, physical activity, psychological aspect should be taken very consciously because the patient might have some psychological issues. Pharmacotherapy if required, and bariatric surgery if the pharmacology of the medication is not enough and it reaches to the plateau phase. So a lot of recommendation came for the how we can manage obese patients. The most important and the guideline, we should not stigmatize the patient that they have obesity, or they are unsuccessful in losing weight. This is very important. And also managing patient expectation and addressing misconception, necessary step to successful management. Actually, most of the obese individuals, they have expectation that they can lose weight more than what is expected. So we should put a target for weight loss, something which is enough to preserve their health, and also enough to treat the diseases they have. So physical activity is very important for weight loss. The daily physical activity is very simple. The patient is encouraged to do simple things daily, like cleaning house, stair climbing, gardening. This is the daily activity, and we progress for more like 5 per week physical activity, like aerobic exercises, and then we need to increase the level of activity with muscle exercise, weightlifting, fitness exercise at least 2 to 3 times per week, and increase the physical activity to the level that can maintain weight loss. The patient physical activity should be discouraged. Patient sitting for a long time, video with watching TV, video gaming. This should be limited to less than 30 minutes. The patient have physical activity more than 1 hour, this considered something bad and have bad impact on the weight. Nutrition is important. I think the dietitian have the presentation on nutrition, and dietary plan are many. Then weight loss interventions is required for some of the patients, and these if the lifestyle and diet is not enough, then we have medication to lose weight, and sometimes you require bariatric surgery. Most of the guidelines recommend starting these interventions once we reach a plateau. The patient cannot lose any more body weight. So there is many medication available nowadays in our country, in UAE. These medications can help in weight loss. The first was 1999. We have the Zenical, which can be very helpful in losing weight in the beginning. We usually start with this medicine. There is other medicine which were approved in 2012. Kismia is one of the medicine. Contrave is also one of the medicine. Both can help in reducing the appetite, and also they can inhibit the center in the brain for the appetite. There is the injectable. We have the Saxenda, which is approved by FDA in 2014. It is used for some time. Now we have much better medication. We have the Wegovy with the one Ozempic in the higher dose can help in weight loss. It is used for diabetes as well. We know that Saxenda, these are injectable, also used for diabetes. Saxenda, Wegovy, and the last one we have the Monjaro. Monjaro proven in 2023, and we are the second country after USA in implementing this medicine for weight loss. It is very effective, more effective than Wegovy, and less side effect. These medication can be started after very good physical and also history taking from the patient to know whether there is any previous illnesses the patient have, and also to do some investigation before starting, if required, before starting this medication. And once you started, you have to follow the patient for any complication, and also to observe the patient weight loss over a period required for the target body weight. So once the target body weight is attained, we need to also continue some of these medications in order to maintain weight loss. If required, bariatric surgery can be started for the patient. We have many bariatric surgery. We know that previously the banding and also the sleeve gastric surgery can be successful, but usually sometimes this surgery can, after a period of time, the patient can regain weight gain. The best is the gastric bypass surgery, which can have very good impact and reversal of diabetes in most of these individuals and control weight very well. The weight loss is maintained over a period of time, and the gastric bypass is better than the other surgery, where either the banding or even sleeve gastric bypass, gastric bariatric surgery. So we can see here up to 15 years, the body weight loss is maintained. Early weight loss predicts ongoing treatment. So the patient have a very good amount of weight loss early, and they can maintain their weight loss for a long time. Combination therapy is required sometimes beside the lifestyle modification, the diet, and the medication. Sometimes even gastric bypass surgery required. So the combination, even sometimes gastric sleeve, after a period of time, they start to gain weight. We can start them on the injectable medication to keep weight under control. So, in summary, obesity is a chronic relapsing remitting disease that requires lifelong treatment. It is associated with multiple comorbidities. Lifestyle changes like diet and exercise are recommended as first-line treatment in all patients. Multidisciplinary approach is essential for any weight loss program. Patient-centered approach involving patient in obesity management plan is critical for a successful obesity management. Individuals who fail lifestyle modification may benefit from adjuvant pharmacotherapy. Bariatric surgery may also be indicated in some patients. And that was the last slide. Thank you very much. If there is any question, I'm very happy to answer it. Thank you very much.
Thank you, Dr. Humam. Thank you so much. Thank you so much. Now, I'm going to be taking the liberty of asking some reasonably complicated questions, sir. Reasonably complicated. But with your vast experience, I'm sure you can help us with a few answers. I was absolutely delighted when you put up that slide which indicated individuals who were overweight. And on the one side, there were the athletes who were muscular, and in the middle, there were those who were obese but without any illness. And the third one was individuals who were obese with illness. Now, my question is the central group, sir, obese without illness. And my question is, this group, is it inevitable that in due course of time, if they continue with that obesity, it will result in some form of comorbidity? And you've described at least 200 comorbidities. So is it inevitable, or are there cases, substantial cases of individuals who can remain obese for a lifetime without any comorbidities?
Yeah, thank you very much for this good question, actually. As it is shown that many of such individuals who have obesity, over some period of time, they start to have the complication of obesity. When they are young, their metabolic body system, they are very good, and the metabolism is good up to a certain period of time. Maybe you encountered a lot of such individuals who have increased body weight, but they are healthy. They don't have any diabetes. Even if we check their cholesterol level, very good. Even there is no fatty liver, and they are active. They are moving without any disease. But unfortunately, after a certain age, the metabolic rate will reduce, and complication will start. The complication usually started because of the body weight. Mechanical complication restarted. starting with knee osteoarthritis because of the increased body weight, back pain, problem in the vertebrae, sleep apnea will be started. After a while, this increased body weight actually is considered as insulin resistance. They will start their metabolic complication, increasing blood sugar. After a while, there will be more cholesterol in the body. These cholesterol, after a while, will deposit it in their body organs, creating more metabolic process in the body, starting with hepatic steatosis, which is fatty liver. Some of these fat will deposit it in the pancreas itself, increasing also the burden on the pancreas. The pancreas will start to have in the beginning more overactivity in order to overcome the resistance to insulin. After a while, the pancreas itself will lose function because it is over active for very long time, and diabetes will start. Actually, beside all of these, ethnicity is important. There's a certain ethnic group, they have increased body weight, either they are active or non-active, but certain individuals, certain ethnic group, they tend to have obesity level, but the complication of obesity sometimes is not there. It depends on lifestyle. If obesity, we can see like a lot of individuals, especially in China, who are doing um, uh, this sport and activity, they don't have a lot of complication for certain period of time. They stay on their health for very long period of time without complication. Certain individual, like and you can maybe you show in certain videos like those Pakistani who carry very heavy weight. They are very big and huge. They don't have complication. This is because their lifestyle, they are very active, either physically active or they tend to be from certain ethnic group. They don't develop these complications. But still, obesity is a risk factor for a lot of complication later in life. So we have to fight it early. The obesity is a risk factor for many diseases, and by itself is considered as a disease because the manifestation of the diseases in obesity is very specific. I hope I answered your question.
Absolutely, 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 absolutely. And you very nicely presented that uh, it is almost inevitable for obesity to result in some form of complication, but the saving grace could be if you remain active and if you manage your diet and other such things, it can postpone the inevitability. But of course, since obesity is itself a disease, the better thing to do is to lose weight. That is excellent. So before I look at the questions that are coming up on the screen, I want to exhaust my curiosity. Now, you mentioned, sir, that many individuals are in remission from obesity, which means that they have attempted some lifestyle changes or whatever with the advice of their physician. Maybe they're on medication and things like this. And then you mentioned towards the end, much to my dismay, that this period of remission may not be permanent. And therefore, I ask you this question. Is it possible, do you think it is possible for any of us to continue on a weight loss program in such a way that we actually keep that weight off? Or is it inevitable that the weight will come back?
Yeah, thank you. This is also a very good question. Actually, this is what we face in the management of obesity, that remission can be attained, but it is very difficult to maintain. The people with obesity, they can lose weight on medication, on active lifestyle modification, as far as they are engaged in the obesity program. and they can maintain their weight as far as they are doing the instruction and taking the medication regularly. But unfortunately, if they start to stop the medication, the weight gain return back. Unfortunately, sometimes the patient will consider it as they regain weight more than the usual before starting the medicine, which is not correct. Actually, they regain the same weight they were before starting the medicine. That's why the maintenance is important. We usually speak about maintenance for the patient from once we start the medication, because we know our physiology, our body will fight the weight loss, will this weight loss considered by our body as starvation. So a lot of counter-regulatory hormones will be secreted in order to increase gaining weight, in order to stimulate the appetite center. There will be certain hormones secreted in order to make the individual seeking for more carbs, more sugar. And so this should be managed with the maintaining either medication or, of course, the lifestyle modification. Medication, when we start these, the injectable or the oral medication, actually, usually we ask the patients to maintain certain dose over a long period of time, the dose which is enough to suppress their appetite. Usually, when you start this injectable, like Wegovy or the Monjaro, once we reach the target, we ask the patient not to stop. We have to maintain that target, the successful program, attain the target. Then we have to be also successful to maintain that one. Maintaining it either by maybe spacing the injection over, like, instead of 1 week, we increase the period to 10 days and then to 2 weeks. And then if they are also motivated and they are controlling their diet and they are doing activity, we can reach to the level that we can ask the patient to take the medicine as required. And means that the patient start to having their appetite back, they can take an injection just to suppress the appetite and continuing their lifestyle modification. There is a lot of successful patients, motivated patients. They are doing that over a long period of time. They are maintaining their weight. And we are very happy to see such successful weight loss, um, which is sometimes equivalent to the bariatric surgery, the same amount of weight loss. We have individuals only on medication losing up to 30 kg of their weight, which is the one can be attained by only bariatric surgery before. So we have very successful stories, but unfortunately, we have also patients who are unable to maintain the injections because of the cost of the injection. They cannot maintain some of the individuals they cannot buy, or even the insurance cannot covering. So sometimes they stop taking the medicine, and we can see them their weight increase in front of our eyes, and we will feel very sorry for them.
Excellent. I'm beginning to understand, sir, that the same way as we may take medication for diabetes or hypertension, I believe that there will be a time in which weight loss medication will also be as valuable. I mean, just the same way as medicine for diabetes is so valuable, I believe that in the future there will be a time in which weight loss medication will be as valuable. Sir, I have many more questions to ask you, but I have to be fair to my audience. So I'm going to move now to the questions on the screen. We have Gina who says that it is seen that many diabetics start losing weight. Diabetics start losing weight. Is this a good sign? A difficult question to answer, sir, but I'll leave that question as it is. Please tell us your thoughts, sir.
Yeah. It is actually very evident. Some of the diabetic patients, if they have no control on their diabetes, they are not taking medication, and the sugar is very high, Actually, these individuals start to lose weight, which is not a good sign. Actually, this is considered like a ketogenic process in their body. We know that the ketone diet can lead to weight loss. These are the things that we are using in keto diet, and we are avoiding carbs and taking only proteins or fat, and there will be weight loss. The same process actually happens inside the body. This is at the cellular level. The cell itself, actually, there is a ketogenesis. There is high sugar in the bloodstream, but the cell itself cannot benefit from this sugar. From where the energy can come? Those individuals, they will start to have the energy from other sources, from the fat in their body and from muscles, from the protein in their body. So by taking this reserve in order to produce energy for the body, which is required for daily living, so there will be destruction of the fat, destruction of the protein, by which there will be weight loss. Those individuals will start to lose body weight. They will have a problem with their muscles. The muscle will be destroyed. The fat in the body will be lost. This individual will have, like in the face, this fat pad will be lost, and this will have actually will be permanent sometimes. The weight loss in such condition is bad. Actually, we see weight loss in type 1 diabetes. It is a sign of type 1 diabetes because there is no insulin in the body, and there is hyperglycemia, high sugar. And those the type 1 diabetes usually in children, they tend to have their energy from the other sources the same way I speak about. So they will lose weight very rapidly in the beginning. In type 2 diabetes, it happened lately when there is hyperglycemia. There is a problem with the pancreatic function, and there is the ketogenic process is started. Weight loss at that time is started. It is bad sign. If we have type 2 diabetes with weight loss, the only medication to start for those individuals is insulin. We have to start insulin for certain period of time, sometimes for a long time, until we regain the pancreatic function back, until the patient maintain their sugar on certain level. Either we continue on the insulin, or if we see that the oral medication can be helping alone, we can omit the insulin. But most of these individuals, their HbA1c, the glycogenic hemoglobin A1c, is very high. So those individuals who lose weight, usually their HbA1c is above 10, usually sometimes sky high. We have patients coming for the first time, their HbA1c is more than 13. We have very, very high results. Sometimes you can not imagine how is this result coming, like 17, and I have one patient 18 HbA1c, which is sky high. These are ketogenesis, and therefore there is weight loss, and it is bad sign.
Okay, that's an excellent message, sir. An excellent message for our group. Sudden weight loss requires you to check back with your physician, who will manage it far better. Thank you, sir. Sir, there is a question from Tanusha, and the gist of the question is, do you advise patients to do a genetic test? I believe what Tanusha is saying is that some of us seem to have a genetic predisposition to weight gain or obesity. Is there anything that we can do if it is in our genes? How can we help ourselves? I
Yeah,
believe that is the question, sir.
yeah. Sometimes yes, it is indicated in certain families. If the family, all the family members are obese, and we did all the investigations, so there is no evident cause for the obesity, and they are active, and it runs in the family. Sometimes yes, genetic testing is important. Or if there is other diseases other than the obesity, there's some other issues like metabolic disorders, Genetic here is important. If we couldn't find the diagnosis, nowadays even genetic for diabetes is required if there is diabetes running in the family, especially if the individual are not that obese and more than one member in the family have diabetes, and there is no sign of insulin antibodies and like pancreatic antibodies, and still there is diabetes in the family. Genetic is important, but for obesity, yes, there is certain indication for genetic testing, although it is not always available, but yes, sometimes required.
So the next question, perhaps from Tanusha itself. I'm not quite sure, but let me check. I believe this question is from Tanusha. By and large, it says that there are many celebrities and influencers who are taking, and the word Ozempic and Monjaro has been mentioned, and injectables has been mentioned, and she is wondering whether this is a good thing and whether they will gain weight. And I would like to also connect you to a remarkable sentence that you have mentioned, sir, a remarkable sentence. I believe for the first time that I've heard it from a doctor, a remarkable sentence. And that sentence is, and I'm reading it as you said it, medication to support exercise and diet. Usually we say exercise and diet to support medication, but you have reversed that and you have said you may take medication to support exercise and diet, which is the essential aspect. So, to go back to the question, is are these medications enough, or do we have to nevertheless continue with good lifestyle, sir?
Yeah. Now, thank you very much for your question and the part of our my presentation about the medication to support lifestyle and diet. Actually, yes, for obesity, sometimes the exercise and lifestyle is not enough. It is not enough to suppress the appetite, not enough to maintain weight loss. So, most of these individuals, to maintain weight loss, we need to have the support of medication to maintain the weight loss over a long period of time in order to stay in the relapse state. So, the remission state. So, and avoiding relapse. The celebrities who tend to take this weight control injectable therapy, actually, if they are taking it after consultation with their physician, and they are sure that there is no other side effects and there are no family history of any cancer, especially the thyroid and pancreatic cancer, and the person himself have no history of pancreatitis, which is known. If the patient have pancreatitis, you have to avoid the medicine because pancreatitis tend to occur in patients who have previous pancreatitis. So if these were taken in consideration, yes, the weight medication can be used to maintain weight loss and to attain the target body weight. Actually, being a medication that not free from side effect, we have to consider these side effects in the future. These side effects are many. Some of them are mild, some of them are lifelong. Like for example, we know that this medication can cause a gastric side effect. Some of them nausea and gastric reflux, acidity. Sometimes other side effect, gastrointestinal side effect, like they tend to have a constipation. Sometimes this problem of constipation is related to the motility of the gastrointestinal tract. Certain individuals, they have irreversible suppression of the gastrointestinal tract. The number of these individuals are a few, actually. The few percentage of such individuals, they have problem with the regaining the gastric motility after they stop the medication. It is evident with Wegovy, the Ozempic, more than the Monjaro, but still it is not a good side effect. The other side effect, we know that the prominent side effect, especially in ladies, they tend to lose hair, which is very evident for such medication. These usually related to the diet they are taking, because after suppression of appetite, they are not maintaining the enough nutrients and vitamins in order to prevent hair loss. Other side effects, sometimes there is side effect related to the vision. There is this related to very fast weight loss, can be related to certain changes in the retina and also in the lens. So we have to put these side effects in the beginning with any individual who tend to take this medication. Other side effect like gallbladder stones, if there is very fast weight loss, this side effect tend to occur. The individual can develop gallbladder stones, and sometimes if we see that, like in bariatric surgery, sometimes we give medication in order to prevent development of gallstones. So there is such side effect. Other side effect nowadays, because we have enough time to observe these individuals after weight loss. Actually, part of the weight loss is also reduction in the muscle mass. So we have to advise the individual not only to take the medication in order to lose weight, but also to do exercise to maintain their body mass. Part of the weight loss actually are muscle mass. So should be from the beginning, we have to speak to the individuals that this medication can lead to such side effect. So the celebrities that are taking this medication, and we can see a lot of also videos and media speaking about the side effect. Why I put the side effect in the beginning, to be clear that these medications are not free of side effect. So we have to be careful. We have to discuss the side effect in the beginning, and we have to use the medication under supervision.
Good. So you've answered so many complicated questions. So I feel it is my duty to ask you a simple question now.
Yeah.
And that simple question, of course, has come up with Gina. And Gina says, is obesity connected? No. Well, does obesity cause chronic disease, or does obesity complicate chronic diseases?
Yeah. Actually, thank you, Gina, for this question. It's a good question, actually, because it's not a simple question. Actually, this is a complicated question. Both are there. Yeah, both are there. That's why I put in the beginning, and this is the most recent update from Lancet about the obesity, because in the last maybe 5 years, we are speaking about obesity as a disease by itself. It is not like a risk factor for a disease. It is a disease by itself. So both are there. It is a disease by itself, and it is a risk factor for other diseases. Like when we say risk factor, like for example, heart disease. Heart disease, we know the risk factor for heart disease are many. One of them is obesity. Obesity is a risk factor for development of heart disease. Whether obesity can lead to heart disease directly, in a way, yes, it can complicate and can cause. And it is similar to the other factors, like for example, diabetes. Diabetes tend to occur in an individual with obesity because of certain changes in their body, insulin resistance, the metabolic changes happen. It is a risk factor, but it's also a cause, actually. Both are there. So, in a way, it is a disease, in a way it is a risk factor. So both are there.
Yes, yes, absolutely. You started by saying that obesity is a complicated situation, and you're absolutely right. You end up by saying, well, exactly the same thing. Yes, you're absolutely right, sir. Your thinking and the thinking of the World Health Organization is spot on. Well done. So thank you so much for this session. And I have to let you know in advance on this forum that I will be visiting you sometime next week, sir. Just
Thank you
just
very
for
much.
your
Thank you.
information.
You are welcome
Okay,
at any
for
time.
my monthly visit to you as usual. Thank you so much.
We were
Thank you
happy
so
to
much.
help you, and
Friends,
thank you very much for
my
having. Uh,
okay. My thanks to Dr. Humam for giving us time for this session. My thanks to our support team that has supported us, and we miss Dr. Wilco, who unfortunately is tied up with other major issues from our side. So we miss him. I hope I've been able to do some justice to the question and answer session. Now, we'll be meeting you again next week on the 9th of May. Till then, goodbye and have a great day. Thank you so much.
Thank you very much.